Hari Om, all. Let us take a moment to feel the light of the life, Chaitanya, within each one of us and that surrounds all of us. A warm welcome to everyone to the conversation with Professor Gianluca Bursi, Adjunct Professor of International Law, Graduate Institute, Geneva. He is also a former legal counsel to WHO. Professor David Legge, Emeritus Scholar and Professor of Public Health, La Trobe University, Melbourne. He is also closely associated with People's Health Movement in Bangladesh. Mr. K.M. Kopagumar, Legal Advisor to Third World Network, and an adjunct faculty with us at Chinmaya Vishwa Ernakulam. So I thank on behalf of Kerala student community and public health enthusiasts to all of you in the panel that we are so lucky to have you here in the toughest of the times our generation is ever facing. Before start, let me just state the objective and the structure of the program to the audience. We have invited the scholars who are involved in working international law to discuss with the role of international law, specifically IHR, in the resistance to COVID-19 pandemic. They will discuss with us the merits and demerits of COVID-19 pandemic and also show us some light towards future research. Professor Bursi will take the question from the general design of IHR and also help us in understanding IHR much better. And he will help us to evaluate the effectiveness of IHR in a very generalistic and legal perspective. Whereas Professor David Legge would discuss the same question from a political economy perspective, and Mr. Gopakumar sir will discuss the development country perspectives. All the speakers will take 20 minutes. And Mr. K. Gopakumar, who will speak after Professor Bursi and Professor Legge, will initiate a discussion among the speakers. After a brief internal discussions amongst them, they will start taking up the questions, now inviting Professor Bursi and Professor Legge to talk on the screen.
Many thanks for inviting me. To me, it's a particular pleasure to be able to have this conversation with an Indian university, also because my wife is Indian. She's from Belgaum in the north of Karnataka, so I feel very close to India. I've been there several times. I got married in Bangalore, so I have a very close affinity to India. So there's a particular pleasure to me. So what I will try to do in 20 minutes, as Professor Nitin said, is to try to give a bit of an overview on the core, if you want, of the legal and institutional, not only response, but attempt to prevent the kind of events that we are living now. And that means the role of WHO as an international organization, in particular as the manager and custodian of the international health regulations, so the IHR. These are instruments that are not probably terribly well known to many international law students. Health law is a relatively young field with just a handful of dedicated international instruments. And so, unfortunately, health law becomes topical at times of crisis, when everything becomes more difficult and sometimes mistakes are made, and we find ourselves in the situation that we are experiencing now. So, I hope to be able to bring a little more clarity on that. So first of all, just 2 words about the historical context, because many people think that WHO is the first international organization in the field of health, and the international health regulations, I would say IHR, using the acronym that is quicker, they were revised in 2005, were just for the first time conceived in 2005. But what we have now is actually the latest historical manifestation of a much longer history that starts probably in earnest in the 19th century. We go back 200 years. And they were basically confronting the same problems that we still confronting today. That is to say, how to prevent and to contain epidemics or diseases, of infectious diseases that travel with people, that travel with merchandise, that travel with means of transport, whether it's the sailing ship in the 19th century or the jet plane today, and that travel with animals, armies, and so on. So in a way, the what we call globalization today is not so new. The wave of free trade in the 19th century is exactly what started the movement that culminated with the creation of WHO and with the IHR that we now have in the shelves. The more liberal and more globalized the world is, the more chances there are for diseases to travel and to travel quickly. So that just to, in a way, put a bit of context, because the world has been struggling for centuries, and there seems to be something fundamentally difficult, almost insurmountable, when it comes to effectively stop a disease. It was cholera in the 19th century, it is COVID today, and when COVID is over, hopefully soon, it will not be the last one. So the mankind has really been struggling to give itself technical tools, scientific knowledge, but also institutional and legal tools, because the obviously states cannot act in isolation, and so early on there was a need to have coordination instruments, to have public health defenses that would not stop international trade, as unfortunately we are witnessing today, and that would somehow create a common ground, a level playing field that would harmonize international response. And again, we see the lessons today. Many countries are doing wildly different things, and that is weakening probably the global response. So the world is not learning much, but still we have arguably side, and we also have pretty credible institutions and legal rules. So what was the, if you want, the traditional approach, and what is so revolutionary about the international health regulations? The old approach was, first, we know the diseases we are fighting. So we only address those diseases. And at the time were yellow fever, were plague, were smallpox to a certain extent, and in particular cholera. We know the enemy, and so we know the weapons. And so there were a set of fairly rigid measures, and states could not go beyond those measures, because otherwise they would start interfering too much with trade. The second is, let's stop the disease at the border. Let's stop it at the port, at the airport, at the border crossing point. So we don't look inside the states. We look outside to the enemies that can come into our territory, and we stop at the border. And as you can see, the temptation is still very strong today, and you see it's not terribly effective. The third was creating institutions, common institutions. The first institution that was created was in the Americas. What we call, is still in existence after more than 100 years, is what we call today the Pan American Health Organization, which is closely associated to WHO. So not only we want common rules, but we want joint institutions to manage those rules, to be a clearinghouse of information, to give advice, hopefully also to provide assistance. So all this culminates with the creation of WHO, which is obviously much broader than just epidemics. If you look at the constitution, if you look at the history, it's an organization that really goes in 180 degrees and have a very modern concept of health, health as a human rights, health as the outcome of what we call determinants, which is also other factors like housing, like environment, like water, like nutrition, like access to healthcare, like social insurance, and so on. And then let's continue, but this time focusing on WHO, this tradition of common rules. So the old international convention becomes the international health regulations. And these were thoroughly revised, as I said, in 2005. Why? Because the old approach proved inefficient and became obsolete, because more and more diseases kept emerging. Think of HIV/AIDS, that was a big page turner in the history of global health. But also coronavirus. We didn't hear about coronavirus in mankind before SARS. Hemorrhagic fevers like Ebola, avian flu, and so on. So all kinds of new diseases. And so not only that, but also the globalization of risk. Disease can spread not just through biological agents, but also imagine through a nuclear accident. Remember Chernobyl, think of Fukushima. Also through chemical agent. Imagine, unfortunately, it's happening in India right now. Imagine a major chemical spill in a river and people die in different countries because so that the toxic wave goes down the river. So you have a globalization of risk. And so the modern approach is to take into account all these risks. So just still to give you the end of the context, what was the ultimate push to revise in the IHR? It was the famous SARS outbreak in 2003. I'm sure you'll remember it. Everybody was panicking, the first big pandemic of globalization, and WHO put itself at the center of the response. And there was a very brave, very bold director general at the time, the former prime minister of Norway, Gro Harlem Brundtland, and she did not hesitate to criticize China, that was concealing cases of SARS, to slap travel advisories that made the travel to Hong Kong, to Canada, that were the two big epicenters, collapse in a matter of days. So do things that first were very effective in stopping the outbreak in a matter of months. And with less than 1,000 dead, it seems a lot at the time, and today is less than the daily report from many countries. But also showed the power of WHO, a power that was disconnected from a legal framework. And so that lesson and the fear of a pandemic of avian flu sort of gathered a momentum to revise the health regulation. They were adopted in 2005, entered into force in 2007. They are legally binding, they're like a treaty based on the constitution of WHO, and they have 196 parties, so they're absolutely universal. It's all member states of WHO, 194, plus two small European states, the Holy See, where the Pope is sitting, and Liechtenstein, which is at the border between Switzerland and Austria. So why are the IHR so innovative? First of all, because, as I said, they have an all-hazard approach. They don't just apply to a list of diseases, or not even just to biological agents, but they apply to chemical and nuclear. They even apply to an act of bioterrorism that spills pathogens, lethal pathogens internationally. Imagine that COVID was an act of bioterrorism. The health effects would fall under the IHR. So the IHR became an intensely political instrument. Because they are an interface between public health, but also international security. And that makes the conversation and the politics around this instrument very complex. The second, because being so open-ended, they need to completely rethink what kind of tool we have for surveillance, for assessment, and for alert. And that is the soul of the IHR. There are misunderstandings sometimes. The IHR are an operational instrument that can materialize billions of dollars and put together thousands of people. That's not the purpose of the IHR. Maybe they will be revised in the future, but that's not now. So we have to be careful about over-expectations, because over-expectations bring easily a sense of failure. So we need to be very clear and very realistic. The purpose of the IHR is surveillance, as I said, assessment of health events, alert, and coordination. Try to ensure a coordinated international response. How does this play out? It plays out in a kind of bargain between states and WHO. What do states have to do? States, first of all, and that's been a very unsuccessful challenge in my view, they have to build what the IHR call core capacities. And that means not just having a sort of doctors at the airport or a laboratory at the port. It has to do with the national health systems of states. It's a very intrusive obligation. And so national health systems need to be able to be effective and resilient enough to allow for surveillance, detection, prevention, and control. And as you can see, national health systems did not do very well during COVID. So maybe states, when they revised the IHR, were overambitious, but that's a linchpin of any system of health security. We are as strong as the weakest link in the chain. That's a big open challenge, but that I hope that COVID is a lesson, should be a big lesson for the future. We need well-financed, resilience, equitable, and solid health system. I'm Italian, and you see what disaster we had in my country. It has one of the best public health systems in Europe, and part of the system imploded or was under severe stress in a matter of days or weeks. The second set of obligations for states is they need to assess health events that occur in the territory. They don't need to put a label on them. They don't need to conclude, oh, this is influenza or coronavirus or something else. They need to run what they are observing through an algorithm, literally a set of boxes, which is part of the IHR. And if they check some of the boxes, that they must notify WHO and do so immediately. And after the notification, they need to keep cooperating with WHO and providing information about the event, about the measures they are taking, if they are able to identify the agent that is causing the disease, and so on. And that, as you know, is one of the criticisms against China, that China delayed the notification and was not transparent and candid enough with information that it had. We don't have the full evidence, maybe we never will, but that was part of the criticism, and that's an essential obligation, because if states don't do that, they frustrate the whole purpose of the IHR. So capacities, due diligence in assessing what happens in the territory, transparency, good faith, and collaboration with WHO. These are the fundamental obligations of states. What does WHO do? WHO becomes sort of a manager and a shepherd of the international response. WHO participates in surveillance, and in a revolutionary change, you can use non-state sources, internet sources, NGOs, other international organizations. It doesn't have to depend only on the state, because by experience, states can be reluctant, or they can even be unable to really detect events in the territory. And so it can use other sources, but obviously it needs to bring them to the state, basically saying, that's what we are hearing, please confirm or verify and report back to us. And if you don't report back to us, we'll disclose the information that we have. That's a big means of pressure. Obviously to be used not recklessly, because you are dealing with sovereign states. So WHO does that, and it dialogues with states. It has an active role to play. If you go to the WHO's website, there's a whole COVID page, and there is a chronology of what WHO did. And during the course of January, after China notified the first cases, it started putting alerts and analysis and advice on its website. The climax of this system is what we call the declaration of a public health emergency of international concern. That's an authority of the Director General. And that also is a huge authority given to an international organization. They could declare an emergency even against the will of the states where the event is occurring. The Director General has to consult with a committee of experts that has assumed a lot of power, because basically what they advise or what they provide as information is always more or less accepted by WHO. So there is a system of checks and balances, but there is also clearly an attempt to depoliticize this aspect of crisis management. It should be ruled by public health, risk assessment, good science, and reliance on evidence. And that's why it was really delegated to WHO. This system has been criticized for being too rigid and binary. It is not realistic to only have an emergency or otherwise nothing, because reality is much more complex. And having a more granular, incremental system of alert would have allowed WHO to really set the response under the IHR much earlier than declaring an emergency for COVID at the end of January. That's something that I think will need to be looked at after COVID. And then WHO, after it declares an emergency, can issue what we call temporary recommendations. These are recommendations about national measures, for example, internal coordination, surveillance, contact tracing, testing, vaccination, but also international measures. And these have been the most controversial, in particular, travel restriction, trade restriction, closing a border to people coming from certain countries, and so on. And if you look at COVID again, not many states have complied with WHO's recommendations on travel. At the time where don't suspend travel, and that's what most states have done. So there is a lot of debate whether the system of recommendation is really what we need if states just ignore them. But that was part, and I'm coming to the end of my presentation, if you want, was part of the grand bargain in 2005. States gave a lot of authority to WHO to use non-state sources, declare emergency, making recommendations that bring an element of accountability because states are supposed to look at them. But at the same time, states said, good, WHO, you set the tone, but we take the final decisions. We are not prepared to delegate to you decision that can be life or death for our population, or they can affect the whole economy as they are doing now. So this bargain, in a way, is what underpins the IHR. Whether it was a good bargain or not, I think we'll have a lot of conversation in the near future. But this is what we have. What are the main things that, in my view, will need to be looked at to strengthen the system of guidance and alert? First, this issue of core capacity. States need to invest in the national health systems. And so that has to be seen as a public good. It cannot just be seen as a machine to make money. We cannot have a neoliberal approach in public health. It doesn't work at times of emergency. The second is to have a better system of alert, not just wait for the emergency, act earlier. The third is a probably more credible system of coordination that has to go beyond WHO. There has to be some kind of coordination system where states are able to sit together and to compare their own risk assessment and to coordinate what they're doing. It's irrational what's happening now. Closing borders, disrupting trade, disrupting the food chain, disrupting the trade in pharmaceuticals and protective equipment for no evident benefit besides meeting the panic. We need to strengthen the system way before the panic. We need to avoid the panic. And then finally, we need probably more resources because WHO tries to do what it can with a small budget. The budget of WHO is the budget of the cantonal hospital in Geneva, Switzerland, where I live, just to give a sense of proportion. And so probably we need to strengthen the ability of WHO to properly manage this kind of crisis at the various stages and to be an agent that can really contribute to the prevention or the containment of this kind of crisis. Otherwise, we'll find again where we are now in a catastrophic situation that in my view could have been, if not avoided, certainly contained, had the world been prepared to find tools to better coordinate. And so here we are. I did my 20 minutes and I will stop here. Many thanks for your attention.
Professor David Legge, you may please join.
Yeah, okay. Well, thanks very much for having me, Professor Nitton. It's a privilege to be participating in this discussion. Quite a few things that Professor Birchie has touched upon I was wanting to mention. So he's enabled me to drop a few things. Professor Birchie talked about the revision of the IHRs, which started in 2003 and finished in 2005. And I would like to highlight three issues which I think are still quite critical for us to keep in touch with, keep alert of. One is the issue of taking note of other sources of information, which, as I say, Dr. Birchie spoke about. I think it's quite interesting to locate this in relation to SARS, which where the Director General was quite cross with China for not formally advising WHO of what was happening with SARS when the WHO had known what was happening for several weeks. On account of a Canadian organisation which is actually part of the an important infectious disease network which is established by WHO. But the Canadians had identified what was happening in China, had advised WHO, but it was not able to take action. So, but it's also kind of interesting that in the development of the revised IHRs, the authority to WHO, to the Director General, to take note of other sources of information apart from what the nation state provides was actually inserted by the Director General at the World Health Assembly in 2003, really moving beyond what had come out of the executive board in the 5 months earlier. So it's again, it's to celebrate Dr. Brundtland's foresight that she inserted these items into the this issue into the IHRs. The second issue that I want to highlight is the issue of direct on-site verification by a WHO team. In the version of the revised IHRs, which was produced by a lot of intergovernmental negotiation, there was initially a provision for, if WHO had declared the emergency, it could come to the nation state where the emergency was had, and after collaborating with the nation state, it could undertake direct on-site verification of the event by WHO teams. That was greatly weakened in 2004 and 2005 to have to have the WHO must be that the nation state must speak to WHO, but the idea of on-site verification was not there. The significance of this in the context of COVID is that the Chinese, by the 2nd of January of 2020, had accumulated a cohort of around 41 cases, which included a third of those cases had no relationship to the seafood market. But China kept on using this term, human-to-human transmission has not been demonstrated, between the 2nd of January through to the 20th of January. And WHO continued to repeat this same claim. And it was the emergency committee which advised the Director General to establish an event of international concern, a public health event of international concern. The advisory committee chose not to declare an event at its first and second meetings. And it was only on the 29th of January that the event was declared. So the capacity of countries to delay things is again illustrated. The third thing that I want to highlight in terms of the controversies faced during the revision was the issue of additional measures. In the context of Ebola, Australia and Canada both imposed travel restrictions on West Africa in direct contravention of what the Director General had established as the temporary recommendations. So the issue of additional, and which of course impeded the arrival of commodities for the outbreak and teams. So the issue of additional measures has been a really difficult one. And in an early draft of the new revised IHRs, there was a proposal for a committee of arbitration to really put the pressure on countries to demonstrate that the measures that they are putting in place over and above what has been recommended by the Director General are logical, are not extreme. That was removed and replaced by a somewhat weaker provision. So it's important to understand the politics of the way these things work. I want to say a few words about what the IHRs do not address. And in the context of COVID, they do not address priority setting for research and development or commodity production. So we've known about coronaviruses in humans since 2003, but it's only after a pandemic that there is a boost to research, and that boost then dies down quite quickly. And WHO is not in a position to drive the ongoing research and development for drugs and vaccines and diagnostics, and to drive the production of them at a level which is needed. The second thing that the IHRs do not address is are the ecological and economic factors shaping the genesis of new pandemic diseases. If you're looking at the H5N1 emergency in 2004, it was associated with industrial chicken raising, not just industrial chicken raising, but the virus came via the chicken. In 2009, the H1N1, the vehicle were the pigs, and Ebola, the vehicle was bushmeat and monkeys, where the continued encroachment on the forests forced increasingly poor people to rely on bushmeat and carry the Ebola, and now bats in the context of COVID. So there's a major issue about the ecology and the economics which is not being addressed very effectively. The third thing is that pandemics such as AIDS and AIDS, HIV and MERS, because they do not have a risk of international spread or restrictions on trade and traffic, they don't pass the requirements of the algorithm of which Professor Bucci spoke, and therefore they are not subject to public health emergencies of international concern. So the evaluation of the IHRs really needs to be placed very firmly in the context of the full range of actions and mechanisms and institutions needed to manage communicable disease and pandemic-prone disease. Moving on from, picking up a theme from Professor Bucci, I think of history, I think it's important to recognise the continuing influence of colonialism in the operation of the IHRs. The international sanitary conferences of from 1851 onwards were dominated by the colonial powers, and in many respects the discourse around those conferences was about protecting the great powers from Asians. So Asians, Arabs and Africans. So the ships were coming from the east and bringing with them Asiatic cholera, and those ships had to be held in quarantine. Well, of course, we now know that cholera is a local germ associated with insanitary conditions, and but that was not being addressed. When WHO was formed in 1848, it was also dominated by the great powers, the established capitalist powers. But with the process of decolonisation from the 1950s, 1960s, the developing countries came to have a strong voice, at least in the governing bodies of WHO. In order to restrict, yes, and one of the manifestations of this new voice from the third world is highlighted in the Alma Ata Declaration on Primary Healthcare in 1978, which mentions the importance of a new international economic order. So the developing countries were now saying that the economic order is part of our problem and needs to be changed. The colonial powers no longer held sway in the governing bodies of WHO, but they were able to impose a freeze on the mandatory contributions of all the countries to WHO's budget. And progressively from the 1980s to the present, the freeze on mandatory contributions has led to WHO's budget becoming 80% dependent on donors. And the donors restrict very closely what they are willing to fund, which means that while a formal budget is developed in the World Health Assembly, the realpolitik budget is determined by the donors. I note what Professor Birchie has said about the core capacities and the failure of many countries to develop core capacities. I would like that to be seen also in the shadow of the remarks I've made about decolonisation and colonisation, because the countries which have not invested in developing their core capacities as prescribed by the IHRs are largely very poor developing countries. And they may well have taken a choice that if we have the money available to invest, it would be a better outcome to invest it in maternal mortality or another way of spending money on health. So I think that the failure to implement the requirements on core capacities must be seen in the context of the continuing influence of those colonial relationships. A couple of things about WHO, apart from one thing, apart from the donor chokehold, the US, and supported by some of the European countries, has been driving to reinvent WHO as what you might call a multi-stakeholder partnership, including the transnational corporations and the big philanthropies. The transnational corporations carry a great deal of weight, but of course their case is being pushed by the big donors, in particular the US. The second thing about, before I leave WHO, is that I think it's really important to understand that WHO comprises two entities. One is the Secretariat, and the other is the other governing bodies, the World Health Assembly and the regional committees. And the capacity of the Secretariat is quite limited and sometimes distorted by decisions made in those governing bodies. So when you hear people say that WHO has failed or has made a mistake, it's important to understand the ways in which limitations on the Secretariat arising from decisions in the governing bodies need to be located. In terms of studying the role of the IHRs, I think it's really important to study the sequence of pandemics that we've had, let's say, since the turn of the century. In the context of SARS, the issue was China not reporting early, and out of that came the new power to rely on other sources of information. In terms of the H1N1 pandemic of 2009, the Director General was widely criticised for allegedly overreacting because the pandemic turned out to be not as bad as initially thought. And I urge you to read the report of the Review Committee, which was established after the 2009 pandemic, because it provides a very useful overview of the IHRs. In 2014, the Ebola outbreak in West Africa, WHO's response was a very serious failure. And finally, the World Health Assembly agreed, after previously refusing to agree, agreed to establish a new program called the World WHO Health Emergencies Program, which it should have had for long earlier. Nonetheless, it has been established, and in the context of the subsequent Ebola epidemic in the Democratic Republic of the Congo, it has performed very well, but it is seriously underfunded. I've mentioned, then coming to COVID, I've mentioned the delay in acknowledging human-to-human transmission, which I think is a major issue. But there are other issues perhaps we could come to in the further discussion. The issue of trade-off between health and trade to contain the pandemic with minimum impact on trade and commerce is almost a no-win choice, a no-win situation for the Director General of WHO. I've mentioned the criticisms of Dr. Margaret Chan after the H1N1 pandemic. In the context of developing the WHO Health Emergencies Program, the slogan of "no regrets" was frequently used. No regrets meant that if there's a risk of this becoming a big pandemic, act early and accept that you might have overreacted when it turns out not to be as severe. But the caution of the emergency committee in the context of COVID, the failure, the decision not to declare a public health emergency of international concern until the 29th of January would seem to me to be undue caution. But whichever way you go, I think as a Director General, you'll get clobbered. Finally, I want to say a word about the importance of defending WHO, and in particular, defending WHO from the United States of America, which has been the leading power in seeking to contain what WHO can do. The donor chokehold, the freeze on assessed contributions, really distorts WHO's planning and disables many of its important programs, including the underfunding of the emergency program. And it also prevents WHO from taking actions on the ecological origins of pandemics and promoting access to new medicines, to research and development on medicines and to their availability. And the chokehold has been kept in place largely by a threat from the US to withdraw funding if the assessed contributions were increased. Undoubtedly, if the US withdraws its funding from WHO, the organisation would suffer severe damage. But if it thawed the freeze on assessed contributions and returned WHO's budget to the governing bodies rather than to the donors, it would be an important step forward for public health. I think I'll stop there and look forward to further discussion. But what I might do is to put some further reading into the chat box. Thanks, Professor Nitin.
Gopakumar sir, can we start?
Yeah. Good afternoon, and thank you, Nitin and Professor Bucci and Professor Leke. You have made my job very easy. So I would like to focus a few points on the implementation of IHR or the efficacy of the instrument, mainly from a developing country perspective. So first important issue is that in the history of IHR from 2005 to 2016, WHO declared public health emergency around 5 times. out of these 5 times, 3 times it came under criticism. One for acting very hastily, and 2 times for acting very late. So the question many people are saying is that, oh, it should have been much more of a technical uh, decision and should not be a political decision. So my take on this issue is that it's always be a political and technical decision, precisely because of the many of the international political economy as well as the economic implications on such decisions on the people's life. So there, the decision is going to be political and technical. But at the same time, the question is that which should prevail, and how do we sort of balance that decisions are based on much more technical information and much more based on evidence rather than merely a political decision. So here comes the IHR 2005 compared to earlier instruments. It gives much more powers to secretariat, I would say, instead of director general, has much more powers to make such decisions. There are certain changes compared to the last version of the IHR, but here there is enough powers to do that. But then that takes us to the question that why then WHO comes under such criticisms, or why such powers are not being exercised. That takes us to the question that even though this instrument is there, WHO's own institutional weakness prevent WHO from acting as a acting using its own mandate or its own powers vested on that organization. If you look at WHO's history, only 2 legally binding instruments they have come up. One is a framework convention on tobacco, and secondly on IHR. IHR, of course, was the first instrument. So these were the only 2 legally binding instruments it has come out, and FCTC is under Article, I think, 19, and this is as a regulation. The other one is an international treaty. Why is it so? Interestingly, both more or less came from under same director general who exercised the powers, and also you to note the point that that director general never sought a second term, or it would have been also impossible to get a second term. So there is a WHO always exercised its powers in a very self-restrained manner and seek the cooperation of the member state most of the time, and it never exercised the powers vested on it. So whenever it exercised, some people had to pay some price for that. But I think that's why there are 2 institutional weakness mainly. The one is that, of course, is the funding, which David already mentioned to you. Much of its funding coming from, even for the emergency program, is through donors. It's not from the assessed contribution. And secondly, the director general can currently get 2 terms. So everybody would like to have a 2 terms. I think instead of that, I think it should be maybe instead of 5 years, it should be 7 years, and that's it. So that gives the powers, that gives some kind of confidence to the head of the organization to exercise the powers vested on the institution. So that takes me to the other 2 points related to the exercise of power. One is on the transparency. So people have written already that how the emergency committee works. Emergency committee is actually nominated by from a panel suggested by the member states and nominated by the DG. But all these meetings, you will get an outcome document, but you never get the whether on what basis, what were the evidence these emergency committee considered in their meeting to take a decision. And also, we don't get the detailed minutes of the meeting. So there are people have written already about the decisions of about the committee on Ebola, even though they found that it satisfied the criteria to declare it as a public health emergency of international concern, but the committee decided not to go for it. So why this, if it's an objective decision, it should have happened. So why the committee did not decide? In one of the reports, the statement they say that, okay, it will not add any benefit, right? It will not add any benefit. Therefore, so that so I think if the minutes are available in public domain and the evidences are available in public domain, then there would be some kind of we can ensure some kind of objectivity in the decisions, and we can also ensure that the politics is not overpowering the evidence and scientific based decision. And that also takes us to the question of accountability. So here I would say accountability of member states and accountability of institutions, WHO. Under IHR, all member states are supposed to submit a report regarding IHR implementation to the World Health Assembly. But we will never see those reports, and nobody's in fact submitted. Okay, they just read out whenever there is an IHR agenda, and in 3 minutes nowadays, I think it's a country gets 3 minutes to speak, and within that they have to mention this. Why not there should be a much more of a detailed report submission to the assembly through online. They don't have to read out the whole report, but they can always submit. This is what the human rights bodies do to ensure compliance. So this is an example of non-implementation of accountability framework. Similarly, the WHO, the institution should also make at least an annual report regarding the implementation part of it and the challenges they face, including finance, and also that also ensure kind of transparency in the mechanism. So that is not existing. So having said this, let me move to my second theme. That's both speakers already touched upon is the core capacity issues, and the core capacity issue. One of the IHR review committee report says that around 2012 there were only 42 countries which complied with declared that they have the core capability. When it around November 2015, 65 countries declared that they have the core capability. On the same report says that out of 193 state parties, 84 requested and have been granted an additional 2-year extension for the implementation of the deadline. So that is 84 countries. That constitute around 43% of the membership. And 68 parties have submitted a plan for implementation, and 44 have not communicated their intention to WHO. So you add this 84 plus, out of that 84, 68 had a plan, and 44 never communicated. So 84 plus 44 you add. So that will basically give you the number of countries who actually failed to implement this. And that question takes us to the reason for why there is non-compliance with the core implementation. That's exactly I would like to agree with David. The core capability issue is very much linked with the political economy. And before getting into the detailed discussion about political economy, I don't have any to do that. But most important thing is that you cannot build a core capability only to meet emergency until and unless you don't have a robust health system. The robust health system, you cannot have a core capability only to meet emergencies, right? So that's both speakers said that, and Professor Butti said you cannot have a neoliberal approach to the public health and say shifting the burden to private sector, and private sector will take care of the healthcare sector. This uh, this will not work. As we have seen in India now, as a part of our COVID response, many states have to take over the private hospitals, or even they have asked private hospitals to take the patients from the public hospital who are facing problems with other ailments and so forth, so that they can declare the public sector hospitals as COVID hospitals. So the point is that we need a clear-cut investment in public health and build a robust system. So that will automatically lessen your burden of building the core capability. So primary, when we talk about always health system, we have in mind is a tertiary care. Not exactly. That's not true. We need a very primary, a robust primary health system. That's the foundation of a robust health system. And here also, I would link this to again to WHO's own on incapability to clearly articulate the need for a public health care system with the investment of the government. So WHO of late started saying, at least 2012, 2013, 2014 and all, when we started discussing about the universal health coverage, the advice from WHO is that it doesn't matter whether it's private or public. What matters is the service. So this kind of either here nor there kind of advice will not help. There should be a clear advice, and many developing countries are depending upon WHO's advice. So that take me to the next a few issues. Why the developing countries also use some kind of suspicion with the IHR. One reason is that always that Professor Legge said about the colonial package of the system, and taking it further, what we now call it as a health security approach. The health security approach is an extension of some of the concerns related to the colonial period, and so therefore they think that this may and a complete health system approach will lead to kind of isolation of developing countries. So therefore, they are a bit reluctant. And health security is a very sophisticated word. We use it, but what they also imply by that is the connection of many of these establishments who work on health security is close relation with the military establishment. If you look at much of the core capacity related to infectious diseases existing actually with certain institutions which has close links or they're part of the military establishment, whether it is in US or in many other countries. So therefore, always the international cooperation or international coordination on these issues are viewed with some degree of suspicion. So then the most important issue is that of the kind of political economy we are in, and to have a coordination system, but the kind of political economy we practice, especially the trade, is more of competition and killing the uncompetitive sectors and export as much as and you earn. So if you follow this, or it also translates into the domestic policies, is that as long as you get cheap import, you use that, and you focus where you can export. So you don't have to maintain a national core capacity in the manufacturing. As a result, many countries who do not have manufacturing capabilities in some of these products which are important or uh, critical for the COVID response. So, what was the country's response? Even many countries even do not have a the capacity to assess how much is the inventory and production capacity on these areas. So, if the knee-jerk reaction is export ban, and resulting in disruption of global supply chains uh, and resulting in shortages. So this in a way basically disrupting any kind of coordination effort. Then who will take the lead? Again, it again falls on the international institutions, WHO definitely, and UN. And in fact, UN General Assembly passed a resolution on 20th of April asking the UN General Secretary to prepare plan working along with the WHO and other international agencies to ensure access to these commodities which are currently available and also the future commodities. So, at the but these agencies are not in a position to act because they have various other constraints. They have institutional weakness for that. So some of the important weakness come from the financial weakness because we do not have a sustainable financing model for the international institution. Lastly, I would say every crisis resulting in setting in one layer of governance, one more layer of governance on the emergency system. So, of course, the IHR sets an IHR committee. It is an institutional mechanism that created as part of the IHR. So, immediately after the COVID crisis, the Ebola crisis, we have two more layers of mechanisms to evaluate the or guide the emergency response. We have an independent oversight and advisory committee for the WHO's health emergencies. Then we do have a program, emergency program, and then we do have a global preparedness monitoring board. And now what I hear is that one of the draft resolution currently in negotiation in Geneva is proposing another independent review of WHO's response on COVID. So each crisis is adding one more layer of governance. And this is in a way fragmenting the whole governance mechanism related to emergency response. And more actors are coming in. There are earlier there was only WHO, then HIV added the Global Fund, and then the immunization drive added on Gavi. Then the World Bank came. World Bank set up a specific facility. So now World Bank is co-hosting Global Preparedness Monitoring Board along with WHO. Then even UN also acted for the first time in Ebola. UN also set it up, UN response. So multiple actors are coming in, but who has the mandate to coordinate these actions? I would say it's with the WHO, and therefore it's the time also we do have this, we do understand these limitations of WHO. We do have criticisms about some of the actions of WHO, but that does not mean that to dismantle this organization or weaken this organization, but it is a time to strengthen this organization because which has the constitutional mandate to coordinate the international health. Thank you.
We do have some questions in Q&A. Starting with Maitreyi Hegde, the question is like whether WHO has any power to coordinate a global network of NGOs directly than coordinating with nation states. Is it a possibility within the scheme of WHO?
But maybe I'll give it a start. WHO cooperates a lot with NGOs. Obviously, they are the essential partners. There are about more than 300 NGOs that participate in the governance, in the meeting of the governing bodies. NGOs are implementing partners in many projects. They are watchdogs, obviously. Third World Network is a good example. They bring the voice of essential communities in public health, doctors, patients, students, nurses, hospitals, and so on. So there is already a common work. Coordination is a big word. You coordinate if you have the authority to coordinate. And I doubt the WHO has this authority of being like a universal global coordinator of NGOs. But I'm not even sure whether it's necessary to think in terms of actual coordination. To me, what's important is the quality of the work done together. Under the IHR, again, WHO can act on information coming from other sources, and NGOs can be a very good source. Professor Legge, I think, did an excellent job of going back to the early ideas of what the IHR should have looked like and how much they were watered down. But again, let's put things in context. The very fact that an international organization can, for example, act on an email from an NGO saying, we are on the ground in country A, and we are seeing people hospitalized with weird symptoms that don't match any disease that should be present now. And the fact that WHO does act and can confront a state with those information, I wouldn't underestimate that kind of power that represents. So again, maybe I'm after working 30 years in the United Nations system, becoming too positivistic and too jaded. But I think we need also a good dose of realism of how much international organization can do. And I think that's been one of the threads across our three interventions.
Yeah, can I respond also, Nitin?
Yes, please.
I value the fact that WHO is a member state organisation, and I come from an organisation, the People's Health Movement, which is spends a lot of time watching what WHO is doing. But the two areas where I would suggest we should put more focus in terms of strengthening the role of the way WHO works, firstly is democratising the structure so that the member states can expect that their contributions will be, their budget will be implemented rather than being held in what I think of as a chokehold by the donors. But the second thing is to make the member states accountable for the policies that they promote in secret and in public around public health. So from our organisation, we want to hassle WHO to make them more transparent and make them adopt better policies, but we also want our countries to strengthen their own democracy so that they are paying attention to global health issues, sharing it with their people and coming up with policies which reflect people's needs.
Professor Bursi, the next question is regarding towards the negotiation stage of international health regulations and involvement of China. I would like to not probably call it in very short, very narrow way in involvement of China. Probably, if you can reflect upon the entire the situation during the negotiations for IHR, especially scholars like Kamrat Scott has written a lot about it and how post-SARS politics has diluted the thing. So probably if you can explain a bit further on the negotiation stage, what happened during it, it would be very good for the people in Kerala.
Yeah, very quickly. I happened to be there. I was in the legal office at the time. I wasn't the legal counsel yet, but I was part of the team that worked actively on the revision. First of all, as I said, SARS gave the tone to that revision because the IHR, to a certain extent, codified what the Secretariat was already doing in terms of dialoguing with states, doing risk assessment, doing some surveillance, using non-state sources, using networks of experts and institutions, both for alert and for response. So it's interesting that there was an attempt to codify what happened in practice because it had been successful in the case of SARS, but at the same time containing what was seen as a quite striking amount of power on the part of WHO, on the part of the Secretariat. And that in a way, and this again is one of the threads of our statements, and as you know, the tons of literature, both international relations and international law, what is the nature of international organization? What is the role? Are they just agents of member states? Are they more? Do they play an independent role? What are the conditions in which this role can be played? There's a lot of scholarship that in a way reflects a particular view of the world, but I think it has also to reflect political choices and political constraints. And Professor Legge put his finger on the wound when he mentioned the funding of WHO, the extreme reliance on voluntary contributions that intuitively made the Secretariat less enthusiastic about being too critical for fear of losing voluntary contributions, in particular by the big donors. So sorry, I'm digressing now, but the revision attempted to codify good practice to reach what was seen as a politically acceptable bargain between the authority of WHO and the authority of states, certainly watered down many of the things that we in the Secretariat proposed in the initial drafts. And also, interestingly, sort of brought up some of the real priorities in politics, because the public health part was agreed relatively easily, and what remained was security, sovereignty, and trade. So the provisions that had to do, for example, with this early warning on bioterrorism, with again, the balance of the grand bargain were the hardest to negotiate and were sort of agreed at 4 a.m. on the last day of negotiation. That's why sometimes when you read them, they are a mess because they are the outcome of very difficult compromise. And so that shows you that the IHR are not just a public health instrument, they are deeply political instrument. They touch areas of international politics that go way beyond health. And that's why that to me is also an element, a challenge, an element of weakness for WHO, because sometimes the decisions about national and international measures are not taken by health ministries, which are typically the constituency of WHO. They're taken by defense ministers, by trade ministers, by prime minister, by president. And so the challenge is how to reach an element of coherence and coordination among these different sectors. But this goes way beyond WHO and way beyond the IHI measures.
Can I leap in and ask Professor Birch a question? You've talked about the IHR's responding to the actions that Dr. Gro Harlem Brundtland implemented for SARS, but David Fidler actually says that SARS was an opportunity to deploy a lot of the strategies which were already being developed by people like yourself in the context of developing the IHRs. So obviously it could easily be both, but I'd be interested in your comment on that.
But as you know, the Health Assembly had asked the Secretariat to revise the IHR in 1995. So, and we had many years, I joined in 1998 and I wasn't really part of some of that work. And that was remarkably unsuccessful. We didn't find a good alternative that was realistic also for developing countries to implement. So that's why the Secretariat started doing things without a legal basis in response to needs, because you had emergent diseases. There was a need. There was a need for guidance, there was a need for alert, there was a need for response. And that without a legal basis. I remember distinctly when Dr. Brundtland put out those travel advisories that my boss, the then legal counsel, was terrified. Because what happens if China and Canada come and challenge us? What is the legality of what you're doing? You're damaging our economies on what basis? We didn't have a legal basis. But what is interesting is that nobody came and challenged the legitimacy of what we're doing. They challenged the merits. They were saying, no, everything is under control. Please don't do that. But there was not an outright challenge to that self-assertion of emergency power. They really responded to needs rather than emergent from a codified legal basis. So it's a chicken and the egg, if you want. But to me, I think it's realistic to say that SARS showed the amount of emergency power that could be self-asserted in the right circumstances, which was a bit of a legal vacuum, of political defensiveness on the part of China, of interest in strengthening that instrument on the part of Western countries, maybe for ulterior motives, like security, biosecurity, and so on. So to me, it was an alignment of the stars that unlocked the will of member states to, we need to really revise the IHR, but at the time was a golden opportunity to put checks and balances and contain the power. So whether it was successful or not, I don't know, but I think that was the dynamic as I saw it at the time.
So can I ask another question, Nitin? The IHR's 2005 allows the Secretariat to receive information, act on information from other sources other than the country. China has a law, apparently, in the health department, which says that people may not speak publicly about health issues without going through the National Health Commission. Was that law introduced specifically to undercut the provisions of the new IHRs?
I don't know. I really don't know. I mean, given the level of political and social control in China, I think it goes way beyond the IHR. Control of information is rewriting and that's frankly what China is doing now. They are rewriting and controlling the narrative. They are erasing any evidence of what could have happened. So even though Trump is rattling the sabers and threatening God knows what, you need evidence for what happened and didn't happen. That evidence doesn't exist anymore because the level of control of China, including having its own internet, which is disconnected by and large to the rest of the net, allows it to control the evidence and the information. But that to me goes way beyond health. It's part of the political model of China.
WHO has an office in Beijing. Presumably they were much closer to what was happening in the early weeks of January this year.
Maybe that's speculative. I cannot say. I know that the people from the country office went to Wuhan mid-January, and so together with the Chinese authority, that was not like a surprise inspection like on a nuclear facility. So I don't. They saw what they saw, and they made their own assessment. But exactly what happened, I'm sure there will be plenty of investigations after things come down, and I hope that will bring a measure of clarity, because that's what we need. Otherwise we feed into conspiracy theories, into disinformation, into pure weaponization of public health, and that's so negative. But again, to me, the power of China to control the narrative is unmatched, and so I wouldn't hold my breath for what can come up.
So that's, may I ask further on this issue? So there is one of the criticism on WHO is that it's a contradictory recommendation. Of one way, WHO is saying social distancing, and at the same time saying no travel bans, or even on late as 13th or 14th of March, also WHO criticized countries for imposing travel bans, saying that there is no evidence on travel ban. So some people are saying this is sort of mutually contradictory recommendation. And you also, I think, I read, Professor Bucci, you also mentioned that at one point of time, WHO needs to explain this thing, in a way to prove itself, its transparency and accountability. So I would like to hear from you further on this. And also, Professor Leke, you can also look at historically what is the evidence on travel bans and or travel restrictions and epidemic. Thank you.
Yeah, I know this is a bit of a messy story with COVID. I must say, and this is anecdotal because I'm not a public health person, but I sat in quite a number of emergency committees, or H1N1, Ebola, polio. There is a very, very entrenched consensus in the public health community that travel restrictions don't work. That's not instrumental, that's not political. It's really a very deep consensus that the disease will reach you anyway because you cannot seal yourself from the rest of the world. It's absurd. Because it creates a false sense of security, because it creates more damage than benefit in disrupting trade, is affecting the possibility of bringing aid to affected countries and so on. It's very, very entrenched. And so I'm not surprised that that was like the default at the end of January. And the problem to me is that the emergency committee has been silent until the end of April. So what happened in the meantime was not under the IHR. So there was an element of contradiction. If you look at the emergency committee statement on the 30th of April, even though begrudgingly, it basically admits, acknowledges that there are travel restrictions, but they have to be targeted, they have to be temporary, they have to be proportional, they have to be based on evidence, and in particular, they cannot be a panacea in isolation, and that I totally agree. They need to be part of a package of measures. They basically had to gain time to do other things, to get better prepared. And so I think that WHO has come around a little bit and has acknowledged that that's what countries are doing. And under certain circumstances can have its logic. On social distancing, if you look at what WHO has said, and I can't say that I read all the guidance because there are hundreds of pages on the WHO's website, I haven't seen a clear endorsement of physical distancing. WHO talks about contact tracing, talks about quarantine, but quarantine are individual measures. They can be small community measures, but I don't remember WHO even addressing the whole locking down of entire countries, like what's happening now in the world. And I wonder why. Maybe because it doesn't want to take a position, or maybe because the IHR are fundamentally about international spread. They're not about domestic management of diseases. So maybe it felt that that was a bit outside the remit of the IHR. But I found it striking that, as far as I can see at least, it doesn't really expanded on the model of social distancing that has been adopted in the last few months.
Can I say that I share your skepticism about this evidence about social distancing? I'm persuaded that social distancing and travel restrictions may have had an impact, but I have not seen anything which looks like evidence about these things. I make the point that the first International Sanitary Conference in 1851 was called by the French Minister for Trade, not the Minister for Health. And the trade people have been driving this for a long time. I'd like to say I'm not sure that this obsession with not interrupting travel and trade is a feature of public health culture globally, but it clearly is a feature of WHO culture globally. I think that and I think it would be a good thing to call it out and ask for the evidence.
Professors, we have a few more questions in the chat box. So the last one was from research scholar Paul from CPPR India. And there is another question probably public health scholars like Kopakumar sir and David Legge sir can answer. This is from Saurabh Sinkanapalli. He's asking about whether there can be some sort of compulsion to have a certain minimum amount of investment into the national health systems on the side of WHO. Probably not as a percentage of GDP enough, but probably taking an average of GDP or 2 to 3 years and finding out certain minimum target amount fixed for that. I believe Brazil has already have some sort of such decisions in their law.
There's nothing which is going to happen internationally. It's up to the people of those countries to demand that adequate funding of their their health system. But of course, adequate funding of a health system is statistically incorporates private sector funding, and as Dr. Gopa has said, and Professor Birchie has said that the neoliberal model of a competitive health insurance market providing funds for a private sector service delivery, it doesn't deliver quality or safety or efficiency, and it certainly doesn't work for public health.
So I just would like to add, so the WHO does not legally making any binding commitment from countries to make such an investment, but generally they say 6% of the GDP as a public investment is required to have a robust, is desirable. But if you look at the example of Sri Lanka, it was doing wonderful work in the public health system, around 3%, around 3% of investment in the GDP, and now they are enhancing it to the target is to reach 5%. So I am saying is that what we require is not the investment. What we require is the public investment in the health system, which at least we should have to the level of WHO recommended 6% of the GDP. Thank you.
Professor Bursi, there's a question on dispute settlement process of WHO, which has not yet been evoked once in the history. So this question is like, is there any alternative way available to resolve such disputes arising amidst these situations? Is there a better course of action which the US could have followed apart from apart from defunding WHO?
Yeah, that's coming out as a pretty controversial topic, and it's the first time, at least from what I remember from other emergencies, and that obviously has to do with China's role in all of this. So the IHR has a fairly loose provision on settlement of disputes, which is either up to the countries concerned to choose whatever means of a peaceful settlement they want to use, or to submit the dispute to the Director General, which can act like a conciliator or provide good offices, or optional arbitration. Countries should declare that they accept it. No single country has done that, so that's dead letter for the moment. Or if there is a dispute involving WHO, so something against WHO, it will be brought to the Health Assembly. So it will be the collectivity of states parties that will address that point. So in a way, these are some of the not terribly implausible mechanisms to settle international disputes, but until now, they have not been used. Why? In my view, because disputes that emerge during an emergency, let's just use COVID as an example, largely trade disruptions, countries restricting or prohibiting export of pharmaceutical ingredient, including India, by the way, that for a while stopped the export of pharmaceutical ingredients, active pharmaceutical ingredients. Or protective equipment, or ventilators, and so on, or imposing sanitary conditions that disrupt transport and trade. So you have food rotting at the border and people going hungry inside the country and so on. These are not the disputes that lend themselves to lengthy judicial procedure. If I have this problem now, I'm not sure the arbitration that will give me an award in 3 years make much sense. So I think the challenge would be to try to find mechanism that address quickly, practically, and pragmatically these kind of problems of disruptions when they emerge. And I would have thought that the Director General, using the Director General as a kind of really a conciliator of sitting countries around the table, even discreetly, behind the scenes, not under the scrutiny of the media, and basically compare risk assessment and see whether there is an element of coordination, that to me would be pretty powerful. And I would say, I would see a much more aggressive role on the part of WHO in proposing this, in basically going to countries rather than waiting for countries to come. Because countries can have a political deterrence to do this. They don't want to look weak. They don't want to admit that they made a mistake. So I think there has to be a creative search for mechanisms that are not terribly antagonistic, but they are very practical in addressing quickly and diffusing quickly these kind of situations. Whether then countries will litigate, yeah, sure, maybe. But certainly outside WHO, I don't see why countries should litigate under the IHR trade disputes. They will go to WTO. They will use their own free trade agreements that all have settlement of disputes clause. They will use investment panel arbitration. So there are other forums that compete with WHO, and they are probably more effective when it comes to trade, investment, economics, and so on. To me, what WHO would have an edge, would have a comparative advantage, is trying first to coordinate with other sectors, and second, to try to diffuse at a practical level these kind of disruptions.
Can I just throw in to the issue of the US-China relationship, that people may well be aware that the US has been a major funder of the Wuhan virology laboratory, and there has been a great deal of research undertaken at that laboratory, which is American funded, in collaboration with US virology experts. And critical to that is this issue of growing viruses in ways that might cultivate what's called a gain in function, and which has been declared a moratorium in the US. So there was a moratorium on this particular approach to viral research in the US, which led to increasing funding of Chinese laboratories. So how that gets, I mean, GOPA's called for transparency, and but how that sort of thing gets researched and brought into the open in the context of arbitration or further investigation is hard to know.
Professor, we have already reached 3:30. Am I allowed to take 2 more questions, or should I stop it? It's up to you.
Yeah, please take it 2 more.
Okay.
Yeah, sure.
So this is from Professor Shannu Narayan, who's a member of Indian Society of International Law. She has asked whether states or WHO must seek reparations from China for the violation, or do you think human security angle is also necessary while combating COVID-19?
Maybe the Iraqis could seek reparations from the US for weapons of mass destruction.
Or Afghanistan, for that matter. So yeah, I wouldn't go too far into that. I mean, frankly, this issue of apportioning responsibility, I'm sure there are thousands of lawyers in the US and elsewhere. They are sharpening the knives and looking for any possible forum where to attack China. When you have trillions of dollars on the books, the temptation is very strong. But I'm not sure as strong as the temptation can be, and as it can be legitimate to be upset with China, because I also find it hard to believe that one person eating a pangolin in Wuhan may have caused this mess. Still, I'm not sure that we go very far. I think there's to be another approach. If there has to be accountability, I think the accountability will have to be beyond China, because many countries just sat on their hands and waited until the pandemic exploded, like the US, like the UK, like some European countries, and so on. So if there is a responsibility by China, there is also a responsibility by these states that have been basically passive when they should have looked at what happens there and taken early. So we have to be careful about seeking responsibility, because then there can be also co-responsibility.
I think I do agree that, of course, the whole criticism is the delay of international declaration of international health emergencies. Delayed. Of course, we need to look into that issue, but we also look at that. How many of these countries actually followed WHO's other instructions or recommendations, especially on social distancing and testing? So how many of these countries followed it? Okay, even UK and US was thinking of building herd immunity till second week of March, and suddenly then they, then they started following some of these recommendations of WHO. So while we look into some of these time, we also should look at what really these countries were criticizing WHO, what really they do as soon as they got the recommendation from WHO.
One last question, that is there any scheme to push global pharmaceutical R&D measures, or probably a global R&D treaty by WHO?
I think the sort of picture is bleak because what WHO has done on the research and development front is a new initiative called ACT, Accessing COVID Tool Accelerator. This is consisting of 3 partnerships. So one for vaccines, one for medicines, and one for diagnostics. So this is the beaten path. Okay, this is status quo. WHO has actually, they do have a division called R&D blueprint. The R&D blueprint actually looked at the R&D gap. Oh, not only R&D gaps, all the research gaps related to COVID. The knowledge, they identified the knowledge gap. They have working groups, and they have working groups are meeting, and they are updating this knowledge gap at frequent interval. So we expect WHO using its own constitutional mandate as a coordination function of international health will take it forward and creating an online platform wherein which the various research happening across the world can be coordinated in a better way. What is the purpose of the coordination? The purpose of the coordination is to reducing the knowledge gap, prioritization of the R&D, and eventually push speedy development of shortening the time of product development. But instead of that, WHO did is a product development partnership and completely pushed outside the WHO. So the WHO is only one among the players, and it's not a leading player. It's not even a lead coordinator of any of these platforms, and it is by and large driven by foundations and EU. So EU had a conference. So another important criticism about the WHO's role in the product development partnership like ACT Accelerator is that there is no clarity about the intellectual property protection of the R&D outcome, whether it will be protected through patent or it will be left like a copy left license, whether it will be a IP left form, so wherein which you can really copy this technology and increase the local productions and decentralize the production as much as time you can and increase the availability of the new product. So I don't think so that is coming through. And I got a chance to look at some of the leaked draft resolution, which is also silent on the R&D front. So that way, that part WHO is sort of a failure, and it is drawing the line of maintaining the status quo. That you can link at that. There is no mention about one of the weakness of IHR. You can say not weakness. One of the areas where IHR is silent also on product development, but that does not mean that WHO do not have a mandate. Does not have a mandate. WHO has a very clear mandate on R&D. If you look at the constitution.
With that, let me conclude. Is there anything to add on, Professor Bursio? No. Right. Thank you. Thanks a lot for sharing some valuable moments with us. And I would like to bring to your attention that for us, the Kerala student community of international law, it has become now a challenge to learn international law in South. We were once the part of the prime of international academics in India when Professor Alexandrovich was there. At this point of time, almost all our discussions are concentrated at Delhi. And so this kind of, listening to people who actually negotiate the treaties, who work with institutions are a very small, rare experiences for us. And somehow we are blessed to have you all here. And this is also a very auspicious day for Chinmaya Vishwavidyapeeth because it's the birth anniversary of our beloved Gurudev, Swami Chinmayananda. And, the blessings of Gurudev has come up as what I call in the form of real 3 gurus before us speaking about international law in this day. Thank you. Thanks a lot.
Many thanks to you. Thank you very much. Bye-bye. Best wishes.
Thank you, professors. Thanks a lot.
Bye.
Thank you. Bye.
Take care.